We appreciate everyone for joining. For those of you who don't know me, my name's Eric Mendonça. I help lead the commercial team here at Flexergy, and been here for almost 9 years now, and really excited that our products are getting into practices, and we're getting to talk more about not just the technology, but more of the application of the technology. Today it's about applying a on-site Salmonella PCR into practice. A little bit about the platform. We'll make this quick because I think we want to get to the other details, but really it's a shoebox-sized analyzer that allows for PCR testing, real-time PCR testing, and currently there are three products available: Salmonella PCR, EHV1, and a strep equi assay as well. I think also there is CE available for this session, so just go ahead and reach out to us afterwards, or there might be a link to a form that you guys will send out. But yeah, we're here to improve the turnaround times and just give more information to the veterinarian and kind of have a better pulse of monitoring infectious disease. I think, and we're excited to be able to go into that topic a bit further here. And then two familiar faces, Dr. Bruno Karam, really appreciate working with you and building the relationship closer. Internist at Pilchuck Veterinary, among other things. But again, it's been a pleasure working with you so far, and thanks for sharing your kind of triumphs and challenges implementing PCR testing in your practice today. And also Dr. Ben Sykes, very familiar face. Again, pleasure working with you as well, and here to also share his side and help moderate here. So I'll hand it off to you, Ben, and thanks again, everyone, for joining today.
Thanks, Eric, and thanks, Fluxergy, for putting this all together for us. So yeah, I'm really excited today because the old saying, those who can't do teach. I think in the modern day we could change it to those who can't do consult. And so I'm drifting away from clinical practice, and I really enjoy these touch points about seeing this technology and seeing these things that we do from a development point of view get put into practice. And Bruno is certainly someone who's done that really, really well with this platform. So we're going to have a series of questions here. By all means, feel free to stick stuff in the Q&A as well. And we've got a few topics, so we're going to move through it at reasonable speed and kind of try and keep this more like a podcast style than necessarily a PowerPoint presentation. So Bruno, welcome. We covered this a fair bit in our first webinar, but just to loop back from your clinician perspective, why do you think testing for Salmonella is so important in your hospital?
Yeah, well, first of all, thanks for having me, and thank everyone for joining. As far as the Salmonella testing, I think we've discussed multiple times, and I think a majority of us agrees that we are past the stage of just saying that, Salmonella is there, they're all going to have it, why look at it, and just neglecting the issue at hand. We don't find that as an acceptable approach anymore. I think we evolved to the point of diagnostics and screening tests to know that we can do better. So for me, that was certainly a goal, right? And Salmonella itself has been thoroughly identified as one of the most common pathogens that we see associated with endemic disease in veterinary hospitals. And within that, you have your shedders that are posing a threat to other patients, to your staff, because it is a zoonotic disease. So if there's people that are immunocompromised, there might be a risk. And also environmental contamination. And maybe some aspects of it are overlooked because we always, as clinicians, focused on a patient and what the patient is showing us, and potentially neglecting the subclinical aspect of some patients when they shed, and then also, the human aspect, right? The zoonotic potential. I think we've all been guilty at some point of either eating on clinics or drinking water, whatever it may be. Nobody's perfect, and we probably do a lot as veterinarians. I think you guys presented before as far as the habits of washing hands.
You probably shouldn't.
Yeah. So the overall goal with Salmonella was just to increase the surveillance and be able to isolate the shedding animals in the contaminated areas of the hospital before it had a negative impact on either the patient care, the humans working at the hospital, or the finances of the hospital as well.
And that, I guess that leads to the question, is it something that you've had a specific problem with and this is reactive, or this is something that is risk management prospectively?
We have not had an issue with it that we were aware of. Um, that might be tied on later on, but we probably, as we started doing more and more with PCR, we found there are incidence and prevalence is probably a little higher than I would have liked. We have those numbers for culture, but not so much for PCR. So we are seeing it. We are getting positives as we're looking, and it allows us to, again, take action before having an issue.
Yeah, so that leads really nicely into our next sort of question, which is, it's those hidden risks, right? That we talk a lot about. And so what are your goals? What are you trying to achieve? Not just in salmonella testing, but specifically with the point of care PCR. How does that apply in terms of your intended outcomes?
Yeah, so the point of care PCR, I think the unique thing about it, as we've start having, diagnostic tools that have a small footprint, they are easy to use. They provide a very efficient way to screen your patients in the hospital and still having a quick turnaround. Um, Obviously, if you don't have it, you have to collect your sample, you have to send out with overnight shipping, then wait for the results to come back and actually be reported before you can take action. So the goal for the point of care PCR, obviously, as an IDC tool, is to be able to intervene quicker, right? That's first and foremost. And then obviously you're providing the best protective measures to the patients, to the humans, and to the hospital reputation as a whole, because it takes a lot to build a reputation, but it doesn't take much to ruin. And we know that the equine community is quite small and sometimes a bit of a high school scenario where, by the third person that's telling a story, it's changed from, that is a case of salmonella to the whole hospital is covered in diarrhea, possibly. So, we want to be proactive. I guess that's the best way to put it, and stop an outbreak before it could potentially cause damage. On top of that, you do have obviously the ability to screen your at-risk population, but also your subclinical cases, right, which is important. And it gives you a flexibility to change the protocol as you go. You can adapt to a specific patient, or you can kind of, realize what works and what doesn't for your facility and change quickly while still having the use of the technology. So for me personally, it was just having a protocol that's going to maximize the capability of our staff, but still stay within our operational capacity. Because if you exceed that, then it leads to failure and frustrations from everybody. So those are kind of my goals for using the PCR analyzer.
Yeah, and we're going to talk about that a little bit more, but it's this concept that biosecurity is not all or nothing. I think sometimes it gets tagged with this sort of dirty image that, no pun intended, but this dirty image that if you're not doing this that you saw at this facility that is the world's best biosecurity facility, that you're by definition not doing biosecurity or not doing a good job. And I think it's that adaptation to individual circumstances. One step at a time is a very reasonable thing to do, and one size doesn't fit all. In terms of, we think about this, and we talked about this in the last webinar a fair bit, the different culture, PCR, and the different roles they potentially play. What do you think, and we'll get into this maybe a little bit more later, but what do you think that PCR has brought, or that point of care, that speed of turnaround has brought to your capacity that you didn't have before?
Mostly, I would say intervention, quick intervention, or at least planning accordingly. Because as you mentioned, I don't have the capacity where I am to implement the IDC protocols that I had at the university during my residency, right? And that's true for a lot of clinics. And within the spectrum of hospitals that can utilize the equipment, you're going to have hospitals that have a low caseload, a medium caseload, a high. So they're going to be all over the place. And it has given me the opportunity to at least, again, do something about it and look at it from the standpoint that, knowing and doing very little or a little bit, it's still better than not knowing at all and ignoring a potential problem.
Yeah, and that flows sort of nicely into our next question, which is, when we're thinking about adopting this, whether it be the point of care PCR or adopting this approach, adopting the technology or adopting the mentality of saying, okay, I recognize the risk and I want to be more proactive about management. What are the key factors that are driving your decision making in how you adopt that and, what you're looking for from a technological point of view or a capacity point of view?
Well, first and foremost, obviously accuracy. I think as veterinarians, we all want that. But when you have the background data that you having accurate results that are matching the gold standard, I think that's always great. From the operational side, I would say simplicity is huge, right? I have about a third of our technicians are LVTs that have had more experience with running lab work at different facilities with using different equipment. We do have a dedicated lab at our practice. We actually do most of the IDC stuff ourselves, so the equine staff will do it. But we also have about 2/3 of our techs that are not LVTs. They're either in process of doing it or they're just not LVTs, and we want something that they can all operate. And it has to be something that's easy to operate as well, because time is a factor, right? You only have so many people. You want to optimize your staff and you want to be able to run the samples quickly from collection to preparation to incubation and actual running. So that was all crucial. The footprint being very small, it's definitely a plus. As Eric mentioned, it's the size of a shoebox or half of your keyboard footprint, so to speak. So even if you have a higher caseload, you could potentially run them in tandem, where you can double your ability to run samples and not sit waiting for multiple at a time or exceed the incubation time. So those are important. And then we had to be able to support our caseload, right? Which circles back to the ability of that 1 hour time frame turnaround, which for us, it's great because our caseload, we stay well within that, and as far as the number of daily samples that we run. So it's worked great for us. We do have the option for some reason, if we're busy or we have more samples to run than the time allocated within that 16 to 24 hour, then we can always put in the fridge and run it later. So there's a lot of flexibility in that as well. And then finally, but also critical, is the tech support. I mean, we've had great tech support when things pop up. We have questions about a result, whatever it may be. That's always been easy enough to reach, and it's always been easy enough, if I can't do it myself, that one of the techs could do it.
Yeah, and you don't just have your lab tech, being the one person responsible for doing this. It's it's who's there at the time, right?
Yeah, having someone be able to kind of distribute the responsibilities around, and having the people that can interact and get answers for you, so you don't spend most of your time dealing with things that wouldn't have been easy for someone else to do it, are very critical for me.
Yeah, we'll get into the human error or the human aspect of it a little bit later. So if we start thinking about application, and we start looking, digging down into your protocol, what are the samples that you're primarily running? And what's the importance of those different samples?
So we've had the analyzer, I want to say, for over a year now. At first, originally, we were planning on, I had this idea that I would run both fecal and environmental. I would say at this point, the majority of the samples that I'm running are fecal samples, and then environmental on surfaces that may be at risk of contamination, or stalls from patients that have tested positive after they leave following disinfection. And I would say the least would be reflux. We have run reflux as well and gotten positives on reflux. Fecal testing, I think that makes obviously sense for everyone, the way the organism is shed and the transmission of fecal oral route. Environmental contamination may be something that we might not be as aware of, but it has been thoroughly documented as well as a common feature in the transmission and the accumulation of the pathogen within the facility, whether you're talking about cracks in the surface or the type of the surface. Oftentimes, it can be tricky because we tend to respond well if you see if you see manure on the ground, you're going to clean up and you say, okay, that surface is dirty. But obviously we know that you can have spray from hosing off other stalls or walkways or whatever it may be. So environmental contamination is a big factor as well that we should be aware of. And then, reflux, I think it's a little bit more tricky. We know that it's there. The actual role as far as contamination transmission, I don't think we have a clearly defined status in that yet. But ultimately, again, going back to bad habits, we've all had the instance where you're putting your mouth in the end of a NG tube or something along those lines. So, gotta be aware of it. And it's funny until it's not, right? We share stories of that intern mate that got sick from salmonella, and years down the road is a big laugh. But again, if you have a person that's truly immunocompromised, then at that point it's no longer funny. So it's just things there to keep in mind, and the samples that we are looking at. And obviously reflux as well. If you don't have a patient that's passing anything, we test reflux.
Yeah, and I think that the facilities is a really, I think it's one of those biosecurity things. It's a little bit like the all or nothing, and it's one thing when you've got the multi-million-dollar purpose-built isolation facility with separate rooms, and you've got the HEPA filters, you've got the whole deal, and we know that a lot of big institutions are very fortunate to have that. Back in the day during my residency, we didn't have one. It was built at the end of my residency, and it was in the barn. And, we would just barricade them in the barn, and they'd squirt into the environment. They'd squirt into the hallway, and everyone would sort of clean it up and cross your fingers and hope for the best that the job was done. The private clinics I've worked in, I've never worked in a private clinic that's had a formal isolation facility. We tried in the clinic I was, involved in owning, but, we had wood in there because that was the thing that we, wood and plastic and cracks. So knowing knowing what's there and knowing the risk, and then being able to manage that risk, I look back and go, gee, I was lucky it was in a part of the world where salmonella wasn't very common. And that was part of the decision making in doing what we did. But if I was somewhere else and I knew I had that cracks in the wall, drains, all that sort of stuff, being able to track that from a risk management point of view, I think, has real value. So let's dig in now to, the actual protocol. So I'll leave this up while we chat. I'm dropping it down so we have the opportunity just to be a little bit more personable, but can you run us through what you actually do, how you apply this in your clinic to your patient?
Yeah, the image on the screen is a copy of the protocol that we use that's been distributed to technicians, interns, other doctors. So that's pretty on par with what we do. And I'm always happy if Flexity shares with other people. In a nutshell, every patient that's in the hospital for longer than 24 hours is going to get what we consider a screening test. So that way they pass, the samples collected, we start running. The high-risk patients, your colics, colitis, your NICU patients, Marin-Foes, not specifically with diarrhea, but just all Marin-Foes, horses that have chronic use of antibiotics, those will get 3 samples total, 12 to 24 hours apart. And that's kind of your higher, I guess, level of security. Otherwise, if they're in the barn and things change, let's say you have an arthroscopy that stays longer for bandage changes or whatever it may be, and for some reason that horse becomes a concern, either develops diarrhea or has a fever or any aspect of the kind of triad of neutropenia, fever, and diarrhea, then we have the ability to retest that without worrying about what the initial intake result was. So if the horse was negative, it doesn't matter. We would still retest that horse. We are fortunate enough to have a separate isolation facility doesn't have any communication with the main barn or the inside climate control stalls. So that's nice for us. We also do have a Marin-Foe or the reproductive barn, so to speak, that's completely separated, those mares do not get tested unless they come into the main barn for some reason. So as soon as they are into the main hospital barn, doesn't matter who it is, they will get tested. The ones that are not getting tested, where we kind of made the compromise, are the ones that are just either, they come in at, I don't know, 4 or 5 p.m. and they just stay in to be fasted for a gastroscopy first thing in the morning, they leave, or a lameness that has to stay for additional workup the next day, provided that they don't have any concerns, they don't have to get tested. But again, we're still fortunate enough that if we have to, we can play with the location where horses go within the barn and kind of allocate different risks and decide, for those horses that are not getting tested, so they're not too close to the ones that are being tested. And that all falls under what we consider IDC, as far as billing and whatnot. And we use separate charges for the diagnostic screening. So if we're truly using it as a diagnostic, which is not as common with Salmonella as it is with EHV1 and strep, then that's completely separate.
And when you say, like in your protocol there, reading it, you talk about mares and foals, excuse me, and pooled samples being okay. It's something I admit, like until 12 months ago, when I sort of came back and really started thinking in greater detail about Salmonella. And, if you work in universities, often the protocol is given to you, so you're just following it. To be honest, you don't actually have to give it that much thought. You just do what you're told, which is rare sometimes in academia. But you're talking about pooling samples there. So you say mare and foal pooled, and I think we'll talk about this a little bit more on the next slide. Where does that fit in, like in terms of sample utilization or test utilization or cost utilization?
The pooling part, I think, from the perspective was that, you might increase your chances of catching that positive, essentially. If you have, we also do it for a horse that stays in the hospital, that we don't have necessarily a rush to collect a sample, that we know that horse is going to pass, a few times over the first 6 hours. Then we also pool an individual patient. As far as multiple individuals, I would say that the mare and foal are the unique one where we will collect from both. I have not yet pulled reflux and fecal material. I'm not sure I have a great reason to do it, but that's another thing. And again, pooling does give a different perspective for practices that may have different abilities to implement the analyzer. So there's definitely something that's overlooked in general, in my opinion, with PCR is pooling, because it carries great power, not necessarily for the individual horse, but for the overall testing protocols.
Yeah, it really comes down to, I think, whether we're thinking about the value of the test being the value of a positive versus the value of a negative. So when we're testing individual patients, we're really focused on the value of the positive, because it gives us, it tells us the diagnosis, it gives us a name, and it tells us, a path to follow. When we're thinking about IDC, when we start shifting to environmental monitoring, or we start thinking about screening horses coming into a facility, often the value's in the negative. It's knowing that horse is negative, or being confident that horse is negative. And so I think pooling really sits on that bridge, depending that if you're expecting a positive, then you're pooling to try and, like you say, reflux and feces possibly might increase the likelihood, or pooling multiple samples. When we're expecting negatives, pooling multiple patients that we all expect to be negative, or pooling multiple environmental sites that we all expect to be negative, I think becomes the real power. And that really exquisitely sensitive nature of PCR, I think, is one of the cool things. It gives us the opportunity to play around with that. And we know it's really good at finding really, really small amounts. So it's not a risk if we dilute it. And actually, one of the things we talked about in our last webinar is, when we talk about feces and stuff, is there's actually potentially benefits to diluting, that you dilute out the inhibitors, but you don't necessarily change the sensitivity to a certain point. So, I think that's one of the really cool things that you can play around with this type of technology, and it can be really cost effective if you're testing 5 things for the cost of one, and then potentially going back depending on But if you expect a negative and you put 5 together and you get a negative, then all 5 are negative type of thing. So just continuing, so you sort of touched on this, but I think just walking through this a little bit more, if there's anything we've missed, but yeah, just, capturing those patients and yeah, I guess it flows into that pooling conversation that you can store the samples, you can store the incubated samples. When we want to know about the test, when does it matter? When it's positive, when does it matter? When it's not positive?
Yeah, I think I got a little bit ahead of myself in the last one, but usually those 4 bullets are kind of the general time frames for when we're testing. The if I don't have a particular concern about the patient, then I will get multiple samples from the same one and kind of overcome a little bit of the limitations with the protocol, right? Because we're only testing once. So if you're only looking at one screening sample, you might potentially miss, or there's a good chance that you may miss something. Our colic patients, I guess, are a little bit different because you don't know that they're gonna stay passing or if they got more to pass. So those it's just more of a case by case basis. If you following your assessment, you don't have a strong indication that horse is not going to be passing for the next hours and hours to come, then you can even use the rectal sleeve itself, whatever is left, to run your sample, provided that for us being in a referral setting, it's not uncommon for by the time we get a horse that there's nothing coming out of that stage. So we don't have a whole lot to use.
I mean, there's
as a
something
sample.
coming out, right? There's
Yeah.
mucus, there's other stuff. And that's the thing, is we all get so focused on, yes, we want feces, but at the same time, there's something coming out, and
Yep.
with exquisitely sensitive technology, a bit of mucus is better than nothing, and then you
Right.
might pull later.
Yeah, and then post-op colics are a little bit different in the sense that nowadays most of the colics that end up getting cut, they would either be a resection, that's the most evolved list. They're not just a run-of-the-mill displacement. So these are horses that are compromised to some degree, and you do have some expectation of post-op ileus. We've certainly taken samples from enterotomies during a colic surgery. But afterwards, if they're not passing, that's kind of where reflux will come in, because it's sort of the next best thing. Yes, you can still do a rectal and utilize the sleeve. So I could maybe see that being a good argument for why not. You could run both. That would be an interesting thought that I didn't think about until now. But that's kind of how we approach our post-ops. And then for the colitis and the NICU patients, we try to be a little bit more consistent as far as the 3 samples, 12 to 24 hours apart. But even some colitis, we all know that depending what it is, and sometimes Salmonella would do that and be very good at it, they may not pass. You can see the pathological or the lab work values showing it that horse has a substantial dehydration, hypovolemia, loss of protein. You could see it in ultrasound, colon full of fluid, but that horse is just not passing anything, right, for a little bit. So again, these are instances that we kind of put a time frame on when they get tested, but it also has to do with what the patient in front of you is doing that we can't control. As you mentioned before with pooling, I do think that you could potentially have an instance where if you have multiple horses that they're coming from the same barn and sharing a trailer, right, and they're not staying long in the hospital, but you still want to test them, you could utilize pooling in that sense, and hopefully to get that negative, right. That certainly would be a useful tool to have on board as well. I've not done that yet, but again, it can certainly be done. And there's a lot that I probably haven't thought about that many in the audience have or have experienced in their own hospital that can be implemented moving forward. And I think that's kind of the beauty of having the flexibility with the PCR analyzers, that we become, once we feel like we got it, you kind of become limited to what your habit is, and you don't think outside the box as much.
Yeah, and I think one of the things, and this is a Dr. Percival thing, we're talking about when do you really care about the Salmonella result? And for most of our patients, it's on admission, did they come in with it? The ones that go to isolation or have barrier precautions, we're actually less concerned. It's the ones that are lurking in our hospital, our day patients and stuff like that. And then when they go home, do they go home and have they had evidence of it while they're there? So, I think that testing on admission for those colitis cases, that testing on admission, often it's going to be multiplex because we are, thinking about other diseases as well, particularly the clostridial diseases, but coronavirus, bunch of other things. And then, but it's as the horse goes through hospital, rather than necessarily feeling like we have to submit 3 cultures on daily basis, we can take 3 samples and then run them at our leisure, knowing that the horse is going home tomorrow. We can run it this afternoon to have that answer ready for the discharge tomorrow morning, or we can collect 1 more sample and run the test in the morning, knowing the horse is going home in the afternoon. So I think when we start thinking about it like that, it becomes a really adaptable approach. It gives us this flexibility that we don't necessarily have when we're relying on external sending it out. It's a little bit like our blood samples, right? We'll take our hematology. Horse is meant to go home at 10 o'clock, or the owner wants to pick it up. Let's grab a hematology first thing in the morning just to make sure its white cell counts come back, or whatever factor it was that we were worried about. In terms of implementation into your practice, what are the things that have worked? What are the challenges you've faced of your particular protocol?
Yeah, as far as what works well, obviously the big thing is increasing the number of patients that you can screen, right? And giving you that peace of mind from the hospital perspective, if anything. So if they're in a stall for more than 24 hours, they're going to be getting a screening sample. And then you're going beyond just looking at high-risk shedders, but also the possible subclinical shedders, right? That can certainly affect that we might be, as you mentioned the previous slide, you're not paying as much attention because it's not the one that's screaming in front of you, let's go to ISO, let's put all the PPE and whatnot. So that's definitely important. That's definitely a positive, that it gives you that extra peace of mind. It doesn't mean you shouldn't wear gloves or completely neglect any sort of IDC protocol or measure, but at least you have that. I would say stall disinfection is a big one as well, because you can bunch that into the environmental factor right at the hospital. So if we have a horse that tests positive, we change the disinfection protocol for that particular stall. If it's an elective case that tests positive, that stall is still going to get disinfected as an isolation stall. It's going to get tested afterwards, and we send out a culture at that point as well. Certainly it gives you a safeguard for liability as well. Nowadays, there's a lot of issues with liability, what falls in the hospital, what doesn't. That way you have accurate documentation that you do something regarding IDC, that you've looked into it. Things happen. I've always said, the worst place for a healthy horse to be is going to be the hospital. I don't think anybody is getting defensive to the point of saying nothing can happen in the hospital, but at least you're showing that you're taking measures to prevent it, or at least know and do something about it. Patient care gets improved as well, I would say, with the protocol, right? Not just the patient at hand, but also patients around it. Again, going back to humans and zoonotic disease, you're implementing something to hopefully mitigate that. You do have an option at that point of client and staff education. I think that's huge. Probably not something we think about often, but you get clients asking what that is and what benefit does it carry. And it gives you a chance to talk to them and discuss, okay, biosecurity as a whole, biosecurity at home after they leave the hospital. You involve your staff listens to you say those things, and then they can repeat it to the next client, or they get excited about, taking care of the work they do around cleaning or proper PPE and whatnot. And ultimately, this is something that has been discussed before in other webinars as well, is a team building approach, right? It is something that when you start listening to the people that they're doing it the most frequently, then that also helps you adjust your protocol, right? And that's certainly a plus, because people get involved in it and they're more likely to also be conscious about it. I remember during my internship that was the hospital always had these big mats that were sort of footpath, and you stand back and you look at it, everybody just walks straight around it. Nobody goes through it. I think it gives them a little bit more pride. And I saw a big change with more footpaths being placed in front of stalls. So I think those are all great positives from it, for sure.
And I think
But,
you'd mentioned,
oh,
a
sorry, go
shift.
ahead.
I was going to say, I think in our conversations, you've mentioned a shift from you feeling like you're kind of like the Salmonella police of,
Yeah.
the one that has to constantly patrol the hospital and make sure it's being done, to some other individuals feeling like there's that positive feedback loop. Oh, it means something when I do this.
Yeah. Every now and then you gotta get on it again, but for the most part, it's just became a routine. So that's pretty good. For sure.
Excellent. And that segues really nicely into, the next question, which is, well, first of all, how many positives are you seeing, and who are you, which populations are you seeing them in? And then what are you doing with those different populations? Because this is, oh man, this is a tricky one. Like, it feels like you're opening a can of worms when you don't talk about something, and then all of a sudden you're like, oh yeah, by the way, your horse came here for arthroscopy and it's got salmonella. Not to say that we gave it salmonella, and I think that's that value of testing them early. But it can be, sometimes you feel like it's sometimes easier to avoid those conversations than to manage those conversations. So how do you deal with that? Because I think that's possibly the hardest thing to do in this conversation. It's not the testing, it's how you manage that client, and that patient impact. Not everyone wants to go to isolation. It's big cost, it's big hassle. Everyone, I don't know a single person who likes isolation, likes going out and going to isolation. And we don't want to have every horse go. So yeah, I think this is a great question to spend a few minutes on.
Yeah, it's definitely tough. I mean, that's 100% true. I'm not going to sit here and lie and say that I don't dread these conversations with a client when a horse has to go to isolation, or, we're all guilty of, you get a call from a referring veterinarian and you have this notion that, oh, this is what's going to be, it's going to be straightforward. And then things change in front of you, or you get the blood work that will change what you do with a horse. And then you have to sit and talk to an owner and explain, why the horse is going, and why is it gonna cost more. And I think we all know the value of it deep inside, but it still makes it for a challenging conversation. I do think it's important to explain the relevance of it and approach it from a point of view that's not meant to be a punishment. You're not punishing the horse and the client, but you're doing what's necessary to also take care of other patients and the hospital, right? But I think the positives that we had that were truly would fall into the category of a high risk shedder, a post-op colic, mare and foals, within reason, these can be moved to isolation. I do have a big challenge with critical neonates, for example, because we don't have an isolation stall that I can house a critical neonate. And I'm talking the one that's on multiple fluid pumps, recumbent. They just need the staff nearby. They may need oxygen all the time. These are a bit of a challenge. And unfortunately, at that point, I don't move them to isolation. They stay where they are. From the hospital layout, 2 of the NICU stalls do have a door that faces the outside, so it does not face into the building. So in those instances, the barn crew, cleaning stalls, even some treatments at times, everything's set up on that backside, so you don't cross over with that where horses may be coming in and out of. The stalls that don't communicate with the outside, unfortunately, you just set up a local isolation for that stall, and you do the absolute best you can to, use proper PPE and foot baths and whatnot. So there are certainly challenges. Elective procedures and outpatients, I think they're a little bit trickier, but you still can get creative with it. For example, we have 3 stalls that we use for studs. They're kind of tucked away in the corner. We don't often have studs in the hospital, so we can always toss a horse in there if it's just for the overnight period or another 24 hours until they go home, and then just shift it to end of shift treatments and cleaning the stalls, so we're not doing it much cross contamination, right? Or if you have a case that truly could go home, I don't particularly like to have the ones that are just there for a foot abscess and bandage changes all the time after a week or something. Those, you might have to send them home. You have to say, hey, it's reasonable for the horse to go home. Either we go to isolation or we go home. And I don't think that you're giving the client still the option, and you are having an open discussion about it and doing what's best ultimately for the hospital. But there may be a time that the horse may be moved to isolation for whatever reason, or it may not have been seen as a high risk and then it became a high risk, right? I think chronic use of antimicrobials would be a good example where you might have a horse with a wound or something that would not otherwise go to isolation, but then for one reason or another you catch it, you have to make a decision, right? It's the patient's needs and the hospital needs have to be balanced. But yeah, we've had cases where they don't go to isolation. They kind of get tucked away somewhere else in the hospital, and we get creative with that area, and then we'll treat it as an isolation. But again, it comes down to what capabilities one has in the hospital to do that.
Yeah, the plasticity of owners' willingness to pick up horses, I've often found fascinating. It absolutely categorically cannot leave to, I'll pick it up in 30 minutes, make sure the paperwork's ready, depending on various factors, can be quite remarkable at times. And yeah, and I think those foals, geez, man, they're tough. Like I've never worked in a facility in my 25 years. I've never worked in a facility where I could isolate a neonate, and it has not been possible. The best I've ever been in is a facility where I can get a foal with diarrhea that's stand-in into an isolation facility, and that's it. And even those guys are really tough. They're usually that little bit older, at least a little bit more durable. I was involved in one where we had a Clostridial C. difficile outbreak on a farm, and it was that was knowledge is power. Once we knew it was C. difficile, which is, we worry about Salmonella in hospitals. C. difficile's next level in terms of not wanting that floating around your hospital, in terms of hard to get rid of. It was being able to do that. It was being able to say, okay, now this part of the barn we consider it like a quasi-isolation facility. Does it have the filters? Does it have the outside? No, but we have to make it a backdoor entry or a back hallway entry. And just the knowledge to be able to do that. And, you don't have to have all those spaces to necessarily make biosecurity work the best you can make it work. The more information you have, the best you can do with what you have available to you. So, and what sort of percentages are you getting? You in terms of your colics, your routine patients. That's the one I think is really interesting. It's the routine patients that are.
I think we're sitting just under 3%, I would say, total from all the testing, and maybe I can only think of the top of my head. I would have to go back and look in all honesty. I can only think of the top of my head one horse that was not. So we've had about 7 positives. One horse that I wouldn't have expected that horse to be the subclinical one. And that was a lameness. So the other ones have all had a good reason. We had a gastric impaction that turned out to just be an enterocolitis and ileus, basically, and that got resolved. But looking back, the horse did have a risk factor. We've had mares and foals, for sure. Actually, yeah, mares and foals, mostly mares, then 1 foal and 2 mares. And I'm trying to remember who else, but the other ones would have been colics. So I can't say that I thankfully have seen a lot of the subclinicals. 1 horse for sure, but that's the only one I can think of.
Yeah, and
I would say 3% is higher than I would have expected or wanted. So
yeah, well, I love the rye. In retrospect, that horse had a risk factor, but how many times does it happen to us clinically? We're like, whoops. And actually, if I sort of thought about it in the moment, I realized entirely what I would have seen. But you're busy, you're doing stuff, and those things kind of sneak up on you.
And none of those horses were actually in isolation to begin with.
Well, there you go. Yeah, that's right. They are. When we look at big outbreaks, we talked about this in the webinar. It's never the horse in isolation that shuts you down. It's the one that sneaks up on you. And in retrospect, everyone will look at it and go, oh yeah, someone should have picked up on that. But we're human, right? Like, all the letters after our names or anyone's names don't mean that you're not human and you're not tired and you're not doing all these other things. Like, we've got to give ourselves a bit of slack. Shifting gears and thinking about what are the challenges you faced, what are the challenges you face? What have been, the causes of error where things haven't worked for you?
As far as challenges, I think a big challenge, which shouldn't be a good challenge, good reason, but it is, it's the habit, getting the stuff of where we want to use, because I think we're creatures of habit and we like our daily routines. And um, that's especially true for technicians as well. They have already their kind of set up in their mind as they show up to work, as how the day is going to progress. So that is certainly a challenge, and I would say it took longer than I would have wanted. But again, it highlights the, unfortunately, you have to go through the bad to get the benefits of it. Um, Training individuals, everyone is different. Some pick up quicker, some are very good at the see one, do one, teach one. Others are more visual with looking at the written workflow. So everybody is different in how they pick up. um, Definitely having a system to document it and document the results. And that slide where you had the protocol on the bottom right was kind of the Excel spreadsheet that we use, where we documented by having date, the patient, the stall, the sample collected, and time. So for incubation, running the test, and everything gets initial, like little check marks along the way. So that's important, because otherwise you lose track of where things might have gotten dropped or gone wrong. Reporting results are huge, right? You want to make sure that you report in a timely fashion. There's no point in doing it if you're not going to look at it for another 2 days and see when that positive came up. So, you want to be able to address it promptly. And one other thing that we had was getting used to anticipating you running out of the tests and ordering more. Certainly for the first few months, so we were getting to the point where we didn't have tests, and then there would be a gap in screening between patients, where courses would be coming and not getting screened. But I think we got that down pretty good at this point. I think errors, I'm not saying a diagnostic tool can be foolproof, but for the most part, we're talking about human error, and I'm not including the dilution perspective or the dilution error on the analyzer, the error message that it sends you. I think it's supposed to do that, right? So your staff didn't do it wrong, or you didn't do it wrong. It was supposed to do that, but mostly some attention to detail. If you're tired and you're running around, did you grab the proper reaction mix? We've had that happen. Grabbing the positive control instead of grabbing the actual reaction mix, or using a different test card than the one that the test that you're running. So all these things can happen. Things that come up often, I would say, is pipetting. Not everyone is comfortable and knows how to pipette. And even those that are can make mistakes. I've made the mistake of putting a 200 microliter tip pipette on the 20 microliter pipette, and I've done that multiple times, not just once. So it can certainly happen. Not properly operating the pipette, as you see there, or using the wrong pipette altogether, changing the volume of the pipette to what the test calls for, and matching the volume that needs to be in the card well. Those are all human errors, and these are things that you will go through at some point, and one of these things is going to come up. But it's also important to know that, and know how to change it, right? So it presents itself as a teaching opportunity. In my case, maybe not so much, as I keep making the same mistake with a pipette tip, but for most people, hopefully you can pick up on that.
Yeah, and there is an inherent error rate in the technology. It's very visible when we use this machine, because we get you get the error rate in front of you that it's an invalid result. But it does happen with the reference standard PCR as well. It's just hidden because it just gets rerun without anyone knowing that it was an invalid. So there are some inherent technological challenges, particularly when working with feces, that the inhibitors in feces that will generate some of them as well. So excellent. And then, you touched on this before, but the next question is in terms of what do you see for environmental samples? And just for people in the audience, we're getting to the last couple of slides, going to wind up soon. So, you know, we've bounced a few questions around. If you have any, go ahead and throw them in the Q&A and we'll get to them. But yeah, where, you know, this is very patient focused. Where do you see the need for environmental samples in your hospital?
Yeah, I mean, in my opinion, I think that's our, you know, besides the, I guess you could argue the number of tests being submitted for one patient, right? If you're gonna, we don't have that standard for PCR, but if you're gonna look for a culture where, you know, we accept that 3 to 5 increases your confidence saying that the horse is negative, obviously that's a big pitfall of the protocol we have because we just don't do it that often. But then additionally, the environmental side, I think we sacrifice that, unfortunately, to do the patient more often. We still do it, but, you know, not as much as fecal samples by any means. And I do think it's equally as important. And I think when you go back and you look what's in literature as far as hospital outbreaks, that has been a big factor, right? It's usually the associated with environment and with lapses in IDC protocol as the culprits for a Salmonella outbreak. Right. So environment is very important. I usually will randomly select areas that I think there have had a high risk, whether it's due to foot traffic, seasonality, whatever it may be. You pick those areas, or the OR, for example, gets probably screened more often, where you screen the drains and anerotomy buckets, or the clean OR gets sampled every now and then as well. But you know, not frequently by any means, not like fecal samples. And for, you know, for others, I guess there's also the argument that should be made about caseload. I think from the IDC perspective, I'm kind of fortunate that people in my area are not very well trained to haul in. So even as a specialist, we end up doing a lot of ambulatory calls and appointments compared to when I was in Texas, for example. Everybody would haul in, which makes your daily workflow a lot more efficient because you can see more, but it also exposes you to higher risk of patients that are coming from everywhere to your hospital. So that's, you know, the caseload is going to be important. And then maybe a more university side of things, I don't know if applicable to every hospital, certainly not to where I am. But we also know, I believe it was the CSU paper, that they identified cattle in the same facility as a big risk factor, right? So if that is present, I would say it would be very important to test that as well.
Yeah, and you talked before about the value of you know, testing these patients, and even if environmental's not being done necessarily a lot as a routine screening, knowing that a horse was positive and being able to go back and, you know, double check your disinfection or alter your disinfection protocols to be, you know, increase your level of confidence. And I think that was a really valuable point as well. So we're coming to the pointy end now. What are your take homes? Where do we wrap this up?
Well, I think one would be, as you can see there, you know, IDC, it doesn't have to be an all or nothing. I think it's important to look at the flexibility and arguably challenge yourself to implement something and play with it. I mean, you can't really go wrong. You don't have to feel judged by the protocol that you pick or whether or not it's equivalent to what you did as a student, as an intern, as a resident, whatever it may be. You can create your own, because none of us are realistically working under the exact same conditions, right? Whether it's geography, seasonality, the size of the hospital, these are all big factors, and there shouldn't be a reason why one should be reluctant to at least do it and try to implement. And as I mentioned before, we had our shortcomings here that just didn't work. So then we transitioned to something else. Like we've come full circle, and the point of, you know, knowing is already a big part of it. And even if you don't have an isolation facility, just knowing might give you the chance of addressing it before it gets out of hand, or before you would hate for it. You can say, well, you might have a positive and not have an outbreak, and then you do, and then what? That's going to be a big deal, right? So I think even if you're not reaching the standard you might have been accustomed to at some point in your career or life, you know, you can still do something. And then ultimately the flexibility. I think the flexibility is huge with a point of care PCR. The fact that's, it's sitting right there in front of you. The biggest part of it is going to be the incubation, right? As far as time, the running is simple, the running is quick. If you have a high caseload, you can tandem them. The software will allow you to run 2 analyzers at once, for example. That will cut your time down in half. So there are several ways to kind of play with it and even create a higher source of revenue, because Fluxergy has a great chart on, suggested costs for your IDC or your diagnostic samples that you're running on the PCR.
That's brilliant. Thanks, Bruno. And yeah, no, I really appreciate the opportunity to chat. I always, every time we do one of these, I just start learning these little things, oh, I hadn't thought of this, I hadn't thought of that. And so, we appreciate your time, and we appreciate you, putting what we all talk about into practice and sharing that with us. Eric.
Yeah, no, again, thanks again, Bruno. I feel like reading these slides and listening to you, my life is flashing before my eyes. So it's good to see it come full circle in this regard. But it's, I think one of the big things we are dedicated to at Fluxergy, and why, I think it's again, yeah, IDC, and from being part of the technology and seeing it implemented, none of this is easy, and it really won't be with an infectious disease, and whether it's Salmonella and even going into other organisms. But I think what we're committed to is really giving let's say clinics the help, or facilities. We're working with different showgrounds right now, and various different types of facilities across the industry. And really, I think the first thing that we do is really offer people like Ben and Bruno, specifically Ben and Bruno and Nicola, to say, hey, I'm okay, can you come and have a conversation so we can see how do we help address the situation? Because it's not just testing, right? A lot of the things we talked about today were actually not just testing. It was the logistics, it was the communication, it's the the operations behind it. And so I think that's something I think we're committed to. So anyone in the audience, please feel free to share this, and let us know how we can continue to invest there, because that's really, it's an open forum, since this is a growing need for sure. But yeah, I think is that go ahead, Ben, close it out.
Stick a fork in us, we're done. Thank you everyone for taking the time to sit with us, and Fluxergy for hosting, and Bruno for a great conversation. Thank you all.
Thank you guys.
Thanks.